This conference will now be recorded.
Okay, sorry. Yeah, good morning all. Am I audible?
Yes, sir.
Yeah. Okay, today's it is 90 people and adding. So we'll talk about two of the cyanotic congenital heart diseases, that is ASD and PDA. Okay. Uh, Two other thing, shall we wait for a couple of minutes, because this is a very short thing and it is most of practical importance than theoretical thing. So yeah, we'll wait for 100 and then we'll start. Okay, 91. Okay, 91, 92. 93. Okay, then we'll start up. Okay, today's topic is two of the cyanotic congenital heart diseases, that is your ASD and PDA. Okay, because VSD is another shunt which is cyanotic, but it is a whole topic by itself. So we'll do this two together now. Okay, and coming to the yeah. Coming to the first topic, ASD. See, regarding ASD is, as the name suggests, and everybody knows, it is atrial septal defect. So there is a defect between the two atrias, that right and left. And regarding atrium, what happens is your left atrium is of around 5 mm Hg of pressure, and your right atrium is the least pressure gradient having chamber of the heart, because all of the blood from the body has to drain into the right atrium. So right atrium is zero mmHg, so it is the least pressure containing thing. Okay, so and left is left heart, left atrium is a bit more, that is around 5 mmHg. So the difference between these two is around 5 mmHg. So anywhere whatever the fluid mechanics of anything states that anything will flow from its a high gradient to its low gradient. Okay, so from the left atrium the blood has a tendency to move to the right atrium, because the pressure in the left atrium is more than the right atrium. And when in conditions of a defect between these two, like the atrial septal defect, the blood can pass from the left to the right atrium. Okay, this is normal anatomy and stuff regarding ASD. Okay, so because right atrium has to be the least pressure thing, because all of the blood from the whole of the body has to drop into the right atrium to get circulated into the lungs and get purified and then get again circulated over to the body. So now coming to the ASD per se, it is actually isolated anomaly is around 10% of its incidence, and male to female is 1:2. Females are more, like most of the diseases. And around 50% of children have ASD as a part of cardiac defect. Like it may have isolated factors of other AV malformations and like other endocardial cushion disorders. So in 50% of the cases, ASD will be there. Whenever they say that there is a cardiac defect, then ASD can be there in 50%, 30 to 50% of the cases. That is what. In isolatedly, I mean, like alone ASD is around 10% of its incidence. Okay. And regarding ASD, it increasingly referred as because ASD, because not much of pressure difference, not much of blood flows, and not much of changes occurs in the anatomy of the heart and the physiology of the body, because not much of blood. You can just say that it is a trickling of blood, only few drops or few things just drop into the right atrium from the left atrium. So it is not much that is happening. So most of the patients and most of the children, most of the kids, they tend to be in a rather asymptomatic and at ease. Okay. The only thing when they get referred is when somebody, some primary consultant or a general physician or a pediatrician, when during the immunization routine or routine health checkup, if they put the stent on the baby and they just start listening to this and find some murmur, some abnormality of the heart sound, and so then they'll refer the kid to the pediatrician or an cardiologist to get an echo done. That is how they find an ASD. Otherwise, babies or children, they tend to be asymptomatic, not much of fuss, and they'll be quite good to be it. Okay. And then auscultatory findings are helpful, and ECG is quite helpful because there is a characteristic ECG finding that we'll be discussing. I don't have the pic, but I think I can explain it, how an ECG of ASD looks. Okay. Mm. Yeah, coming to the types of ASD, most of the undergrad books do say that there are three types because of the incidence they do. They want to say only three types of ASDs are there, but in theory, you get four types. That is ostium secundum, ostium primum, sinus venosus, and coronary sinus ASDs. Okay, this order is from based on the incidence. Ostium secundum being most common of ASDs, and then yeah, primum and sinus venosus and coronary sinus. These are the four types. And there is something that we should know about, and whenever you come across any newborn echos, you will usually find PFO, patent PFO with left to right shunt, patent PFO with right to left shunt, like that. Okay, that is your patent foramen ovale, which does not ordinarily produce any shunts. Okay, just there may be some opening, some defect, but blood doesn't flow from it. Okay, that is a very small tiny defect, and it is not of much significance, and it gets resolved by its own, and it's not of any much of hemodynamical significance. That is your PFO. Okay, now coming to the types, these are the three major types, and coronary sinus type is also there. As you must be aware of, coronary sinus is the vein that gets collects blood from the heart and stays in the groove of the groove formed by the left atrium and the left ventricle, and then it just gives to the right atrium from the left end of the tricuspid wall. Okay, that is how sinus coronary sinus is. Okay, that is another type where the defect is there. Okay, now coming to the primum type, as you know, the primum appears, and the defect of the first primum, the main foramen ovale thing, gives your primum ASD, and once it gets closed completely, there is another opening that is formed, that is your ostium secundum, and if that doesn't close after birth, and it gives your secondum ASD. And this is sinus venosus, more on the proximal side, sinus venosus. And if at all there is a coronary sinus, it will be in the more distal part, in the lower area. Okay, that is your fourth type. Okay, based on the primum, secundum, sinus venosus type, and the coronary sinus type. There are four types. Okay, and yeah, in the pre-tricuspid area, there will be left to right shunt. As we discussed, left heart will be having more pressure, left heart will be having more pressure rather than right heart, so your there will be a chance of shunting of blood from the left to the right side. and most probably they're asymptomatic because not much of blood is flowing. Yes, blood is flowing, but not much of blood. And it is usually detected in late infancy and childhood because heart being a muscle, it can accommodate minor anatomical defects. Okay, like, okay, some more blood is coming to the right atrium, so what, it can accommodate it. And atrium gets enlarged to accommodate more blood, and right ventricle gets enlarged to accommodate more blood, and pulmonary artery also gets enlarged and fixed, because this is a congenital, because the defect is there from the birth. So the heart will acclimatize to the minor changes until it can further no longer do it. So not much of defect or not much of symptoms do develop in a kid with ASD, because you in an adult population you can as well find a lot of cases of ASD who are asymptomatic and just incidentally found by taking echo for any other cause. Okay, so that is that common. And yeah, pulses will be normal on examination. You find that pulses are normal, your blood pressure is normal, everything tends to be normal. Okay, but on auscultation you can find, this is classic, okay, wide and fixed split of S2, usually S1 S2, okay, lub dub, it is S1 and S2, that happens. And in the S2 itself there are two things, that is A2 and P2. Okay, A2 is because of the closure of the aortic valve, and P2 is produced by the closure of the pulmonary valve. Okay, usually these two tend to be in the almost the same time, with uh, producing only a single sound like S2. Okay, but what happens in ASD is there is a more blood that is flowing through the pulmonary artery, because there is say 100 ml has come to the right atrium, so 100 ml has to go to the right ventricle and 100 ml has to go to the pulmonary artery. Okay, this is the normal physiology. When there is a defect in the atria, there is 105 ml, that extra 5 ml is being given by the left atrium into the right atrium. So there will be 105 ml of blood in the right atrium, 105 ml it gives to the right ventricle, and then 105 ml goes to the pulmonary artery. So because of there is a little slight increase in the volume, the P2 will close a bit later than the A2, giving A2 and P2. That split can be appreciated. Okay, I think you're getting the point. Okay, otherwise it is S1, S2. S2 has two components, A2 and P2. Okay, you must be knowing S1 is produced by tricuspid and mitral valve, and S2 is produced by aortic and pulmonary valves. Okay, when more blood is flowing, this pulmonary artery valve will take some more time to get closed because there is more blood. So you will, A2 will come first and then P2. So with the difference, you can audibly find that there is a split, and there is something more to the split. It is fixed. Why is it fixed? Is because during inspiration a lot of blood flows into the right side of the heart, because during inspiration your intrathoracic pressure is lower, because the diaphragm comes down, which wants to suck all the air from the atmosphere into the lungs. And also meanwhile most all the blood from all over the body will get into the heart at the same time. So during inspiration there will be more blood that is coming, so the split will be a bit longer. But during expiration, the intrathoracic pressure will be decreased. But having said that, there is more blood that has flown into the pulmonary circulation, which will in return come to the left heart. So during expiration, we expect that the A2 P2 should be a bit narrower compared to the previous one, but because of the more blood that has been again shunted into the left side, A2 will end in the same level. So the split will be a fixed one. Like if there are 2 milliseconds between A2 and P2, it will be the same 2 milliseconds in the inspiration and also in the expiration. Okay, if you are not understanding it, we can discuss in face to face. It is very difficult to understand this thing. So we can get this thing done. Okay, but remember the words, there will be a wide fixed split in S2. Okay, that is characteristic of ASD. Okay, then there will be there can be ejection systolic murmur in the pulmonary area. Why there is an ejection systolic murmur is, as we discussed, there will be more flow of blood in the pulmonary artery. So because 105, I told you, right, there is not 100 ml, now 105 ml is flowing, so that is causing extra blood. That extra flow will cause ejection systolic murmur. Okay, and then there will be mid diastolic murmur on the left lower sternal border. Left lower sternal border will give the diastolic murmur because of your more blood that has been flowing in the mitral valve. Okay, this is the basic physio by which all these things do matter. Okay, and yeah, remember this wide and fixed split of the S2 and ejection systolic murmur of the pulmonary area and mid diastolic murmur, MDM murmur in the left lower sternal border. All these things do constitute uh, your ASD. Okay, remember this, because this auscultatory finding is something which um, you will be asked in your exams. Okay, and coming to the investigations, um, ECG is one thing which is most informative in case of ASD, and the pattern which we see is because the right heart is getting more blood. See, remember in ECG, when there is more there is more blood that is flowing, so the right heart right side axis deviation will be there. When the left heart is getting more blood, left deviation will be there. You just remember these two things. So when there is more blood that is coming from the right heart, so there will be right axis deviation in the ECG, and there will be RSR pattern. Yes, this is important in case of ASD. There will be RSR pattern in the V1 or V3. What is an RSR pattern is your QRS complex is expected to be an inverted V shaped, but that becomes like an M pattern. Okay, that is how it is. Okay, that M pattern is your RSR pattern. Okay, I think it is better to get a pic, but yeah. Yeah, in case of an X-ray, you may not find any cardiac enlargement or any big heart because not much of blood is happening, so not much of volume overload, not much of thing will be there. So there not be much cardiac size change, and there will be right atrial enlargement. That is logical because most the right heart is getting more blood from the left heart, so it has to accommodate more volume, so there will be right atrial enlargement. And there is increased pulmonary blood flow because yeah, more blood is flowing from the right heart, so more blood flows to the pulmonary flow, pulmonary blood also. And echo is obviously the diagnostic modality, and you can get the location and size of ASD, the defect of ASD, and you can also see the right atrial, right ventricular, and pulmonary artery dilatations because it is harboring more blood. And there is paradoxical motion of the interventricular septum. This paradoxical motion is because most of the times the interventricular septum has to move from the left to right side because there is more blood in the right ventricle. It wants to tend to move the interventricular septum towards the left side. That is your paradoxical motion because of your more blood that is flowing from the right heart. Okay, that is all about your ASD. Yeah, this is your X-ray. This is not a very typical feature of X-ray, but you can find not much of heart shadow has been enlarged. It is an almost normal sized heart, but you can see the this pulp. This is not a lymph node or a tumor or a some lesion that is sitting here. This is because of the pulmonary blood flow. Okay, increased pulmonary blood flow. You can see these arteries and veins that have been enlarged in the pulmonary hynal region. Okay. Other than that, the lungs are good and the heart size is also good. Okay, now coming to the entrance questions, lesions associated with ASD primum, okay, ostium primum atrial septal defect. It is inlet VSD, as we discussed, 30 to 50% of them, 32% will have associated thing. Then now we are discussing what are those association. Is this inlet VSD, the cleft mitral valve, and presence and severity of AV valve regurgitation, and partial attachment of septal leaflet of pulmonary mitral valve to septum. See, most of them are your septal defects, okay, mitral valve defects, and AV valve defects, okay, and it can be associated with inlet VSD also. Okay, these are just for the academic purpose. If somebody asks you. Okay, now so you have diagnosed a case. Somebody has sent you that he is hearing a funny sound when he auscultates the heart. So you are the consultant pediatrician or cardiologist. So you have been referred this case. So you have seen X-ray is fine. You found that RSR pattern in the ECG. Your X-ray is good. And child is asymptomatic. Is doing fine. And you have done an echo. And some size the echo is being ASD. You found it. And then how are you going to counsel the parents? And how is the natural history? I mean, how to progress? You have done everything. Then now, what are you going to tell the parent or the child? Is the size matters. If the size is less than 4 mm in by 18 months, there'll be high chance of closure. If less than 4 mm, the size matters. And if the size is 4 to 8 mm, there is only 75% of chances of closure by 1.5 year of age. And if the ASD is more than 8 mm, it rarely closes spontaneously. Okay, the chances. So remember, in ASD, 8 is the number. Okay, if it is more than 8 mm, the chances of closure is very bad, pretty bad. And if it is less than 8 mm, the chances of closure. Again, this 18 is also important. By 2 years, if the sizes are not coming down, if the sizes are persisting, there is less chance that it flows in the future, and you may have to close it by your intervention. Okay. If untreated, what happens? If untreated, there will be congestive heart failure and pulmonary arterial hypertension develops in adults. Because what happens is, over years, if there is more blood that is flowing on the right side, more blood flowing into the pulmonary circulation, so heart will start accommodating, and this beating being for more years. Sometimes the heart says that yes, I can't do no more, and then heart goes into failure. And because of more blood that is flowing into the pulmonary system, your pulmonary arterial hypertension sets in by adulthood. Okay. And something that is very interesting for ASD is, and this is also an entrance thing, spontaneous systemic bacterial endocarditis. Prophylaxis is not required in case of ASDs. Okay, unless it is associated with other defects, as we mentioned, with inlet VSD and other mitral valve defects. Only isolated ASD need not have any prophylaxis, infective endocarditis prophylaxis. Okay, systemic bacterial endocarditis. Okay, this is something of interest in case of ASD. Otherwise, all the heart defects, all the shunt lesions, you may have to give IE prophylaxis, that is infective endocarditis prophylaxis. Your penicillin has to be given for 3 days. If in case of ASD, it is not recommended. I mean, not recommended, it is need not give. Okay. Yeah. Coming to the mode of diagnosis, yes, always your physical examination comes first, your history comes first. Physical examination, in this case, history will be uneventful because there is nothing symptomatic that develops from the child. So your physical examination comes first, and ECG with RSR pattern, I'm repeating it again and again so that you will just remember it. And chest X-ray will be normal most of the times with the mild pulmonary, increased pulmonary blood flow. And transthoracic echocardiography, yes, that is diagnostic and will tell the size, location, and all the things. Okay. Yeah, spontaneous closure is rare if the defect is more than 8 mm at birth, and rare after age 2 years, and very rarely an ASD can enlarge and follow. This is pure bad luck, right? If ASD is supposed to come down with age and growing heart, if the defect is also growing with the heart, that is some bad luck. And a word regarding patent foramen ovale. Patent foramen ovale is usually the echo finding a small defect in the fossa ovalis region with a flap with no evidence of any volume overload or dilatation. Okay, there is a defect in the atrial septum, but there will be no dilatation of the right atrium or right ventricle or the pulmonary artery. But there will be a defect. It is silent and it doesn't do any harm. Okay. Usually a normal finding in newborns. That is what okay. Whenever you get any, you are shown any echoes of your relatives or something, if the thing says that it is PFO, rest assured it is normal in case of newborns. Okay. Yeah, coming to the indication for closure, yeah, when do you want to close it? In asymptomatic child, 2 to 4 years of age. If sinus venosus defect, 4 to 5 years of age. Okay, asymptomatic and the child is more than 2 years, you can, yeah, as we discussed, more than 2 years, the chances of closure is less. So you can close in 2 to 4 years of age. Why? Because you have to close it in 2 to 4. You have waited for 2 years. And the chances of closure spontaneously is very low. So over the next year or 2 to 3 years or 4 years, you may have to close it. Otherwise, there will be overload on the volume, overload on the heart, and the chance of failure is more. And then there is a symptomatic ASD in infancy. Once there is symptoms, yes, obviously that is common sense. You may have to close it. If a CCF, I mean congestive cardiac failure sets in, or if there is a pulmonary hypertension, you may have to close it immediately. It is seen in around 10%, and associated lesions, as we discussed, associated VSDs, associated mitral valve defects have to be excluded. Okay. And yeah, early closure is recommended because you don't want to wait and sit on that because the heart is failing. Okay, if presenting beyond this 2 years of age, elective closure irrespective of age, as long as there is right heart overload and pulmonary vascular resistance, is in operable range. Okay. Elective closure, a 5-year-old comes or a 9-year-old comes with ASD, then you check for the pulmonary pressures. If the pulmonary pressures are, yes, encouraging, I mean, like, they are not too petty bad, because high pulmonary pressures will not allow you to do an operation, because once you close the defect, the pulmonary pressure will suddenly fall. Once there is sudden fall of pulmonary pressures, all of the blood will flow into the lungs, flood the lungs, and there will be acute pulmonary edema, and we can lose the child. So there is a gradient where to which the pulmonary hypertension gets controlled. Only then you may have to operate the child. Okay. Yeah. Methods of closure, previously it is mostly surgical. Now devices has almost replaced it, and more recent mode. And this child weighing more than 10 kgs is nothing to do with the heart. It is to deal with the anesthesia. Okay. And surgery is definite or open or transcatheter closure. You just from the your femoral artery, you just put a catheter and reach your heart, and you just open the device, and the device closes the defect. Okay. And the indications being symptomatic, yes, that is stays the common sense. And in asymptomatic, if the ratio QP and QS ratio is 2:1, this QP means the amount of the perfusion of blood of the pulmonary of the lungs, and perfusion of the systemic. These are supposed to be 1:1. What all the blood is flowing in the lung, it should also flow to the body. Okay. But if this ratio changes, tips off, if there is more blood that is flowing in the pulmonary than the systemic, that is in 2:1 ratio, then you may have to intervene and close the defect. And another thing is your timing of ostium secundum. You can wait 1 to 4 years. If it is ostium primum that is serious, when the primary defect less than 1 year you close, because ostium primums will not close spontaneous, not they're not known for the spontaneous closure. Okay, so less than 1 year you may have to close ostium primums. But ostium secundums, yes, you give them some time till 2 years or 3 years, then you operate. And mortality 1% is there for the procedural mortality and also the defect, because anything can cause an abnormality. Okay, that is a short story about ASD. Now coming to the second topic, that is PDA. And yeah, PDA, you must be knowing, fetal circulation. It is the ductus arteriosus will be patent. It is connecting the pulmonary artery to the aorta. In the fetal circulation, there will be not much of pulmonary circulation because the lungs are not open. Lungs job is done by the placenta, so not much of function of the lungs. So not much blood flows into the lungs. So what happens is the right heart, the pulmonary artery will put all its blood into the aorta through the ductus arteriosus. Okay, that is the normal uh, physiology. And then what happens over time is once there is cord clamp, and then what happens is the pressure tips off after the birth. The left pressures increases than the right pressure. So your aorta has more pressure than the your pulmonary artery. So in PDA, what happens is the blood now after birth starts from flowing from the aorta to the pulmonary. So it is acyanotic. Okay, the pure blood comes and mixes with the impure blood of the right side. Okay, that is what is our patent ductal arteriosus mean. Okay, this is a pictorial depiction. This is in the fetal circulation. This thing, um, yeah, and here the blood from the aorta, this arch of aorta. You remember this thing. This is the left subclavian artery. And then after the left subclavian artery, there is an PDA that is putting blood into the pulmonary artery. Okay, and now the impure blood, which is blue, mixes with this and becomes purplish. That means a mixed type of blood goes into the lungs. Okay, this is what happens. Yeah, how do you diagnose? Obviously, physical examination, history, physical examination, ECG, and just X-ray echo. All of cardiology, you can write this. Okay, and coming to the presentation, how does the child present? Okay, because this is not so subtle like ASD, it is PDA. There is a big considerable amount of blood that flows from the aorta into the pulmonary circulation and puts more volume into the pulmonary region. So there will be congenital heart failure at 10 to 6 to 10 weeks older child, and the child will be presenting with the dyspnea, that is features of heart failure like dyspnea, palpitations, and chest pain. Okay, chest pain in initial years, kid toddlers they can't do, but in an elder you can have chest pain. Okay, yeah, palpitations too, only an older child can tell that. Otherwise there will be dyspnea, difficulty in feeding, and pooling of blood in the pulmonary circulation, resulting in recurrent infections. That is how you pick up a cyanotic heart disease. Okay, then wide pulse pressure. Wide pulse pressure is because there is more blood that is circulating because there is overload. So there will be more pulse pressure. There will be bounding pulses when you palpate for the pulses. Okay, because the blood has to go to the left circulation, but again a small percentage of it is again put into the routine right side. So there'll be adding up of more blood to the circulation, and again 105 comes there, and again of that again 2 ml goes back. So next time 107 comes, again next time a little more comes. That is how the circulation happens, and starts pinting up. Okay, that is how your wide pulse pressure occurs. Okay, wide pulse pressure is the difference between your systolic and diastole. Okay, systole and diastole, the difference is your pulse pressure. And you can find the hyperkinetic heart, and left ventricular apex is hyperkinetic because more blood is percolating in the heart. And loud S1 and S2, and there is a paradoxical split can be present. Paradoxical split is because yeah, it is usually A2 P2. Here they can be P2 and A2 because the pulmonary will stop faster and then A2 appears. Okay, there is a paradoxical split. Okay, then shunt murmur is continuous murmur because this flow will be there during the systole and diastole also, so there will be a continuous murmur. That is characteristic in case of PDS. As the same thing, there will be more blood, so there will be more blood flowing from the mitral valve, giving your mid diastolic murmur in case of PDA also, and aortic ejection systolic murmur because there will be more blood into the system. All these are a little bit similar to the ASD, but what happens is it happens on the right side. Okay, previously in ASD it is the right left side. Previous ASD is the right heart, so more blood flows from the right side, more blood flows from the pulmonary, so there will be ejection systolic murmur of the pulmonary area. And in here it is more blood flowing from the aorta, so there will be aortic ejection systolic murmur. And this MDM, mid diastolic murmur, is the same in both the cases. And continuous murmur is a characteristic feature of PDA. Okay, and these examination findings and the clinical findings are based on the size of the PDA. If it is small, moderate, and large, yeah. If it is a small PDA, it is just like the normal values. 2+ pulses can be felt, and moderate and large there will be 3+ pulse. That is your bounding or extra or hyperdynamic, hyperkinetic. Those type of pulses. And BP, there will be wide pulse pressure in all the cases. Okay, and capillary filling, this is normal in a small PDA, and there will be flushing in case of both these two. And apex, heart apex on palpation will be normal in case of small PDA, and left ventricular type of apexal with a hyperdynamic in case of moderate to large PDAs. And continuous murmur can be seen in all the things. Just remember, continuous murmur can be seen in all the variants, and BP will be wide pulse pressure in case of all the sizes. Okay, and regarding thrill murmurs and other systolic murmurs, there will be more in case of large defects and absent in case of small defects. Okay, this is your differentiation findings. Okay, just remember that BP and continuous murmurs will be there in whatever be the size. Okay, just remember. Other than that, your other murmurs will be more severe in case of large defects and less severe in case of less defects. Yeah, this is your pictorial representation of the murmurs. In moderate PDA, there is systolic murmur with a mid diastolic murmur. There will be systolic murmur with a mild hump of diastolic murmur because in case of large PDAs, and very large PDAs with a severe pulmonary arterial hypertension, you may not have much of murmur. You can get a systolic murmur alone, ejection murmur, that's all. It's not a pan systolic or a continuous murmur. Okay, not mostly. This is your diastole, this is your systole. Okay, pan systolic murmur, and there will be abrupt stop. There is not much of diastolic sounds in case of severe pulmonary arterial hypertension being sets in. Okay, otherwise you can have diastolic things. Okay, these are again your entrance thing. Continuous murmurs, differential diagnosis. Continuous murmur in case of a pink child. Okay, not a cyanotic but a acyanotic continuous murmur. You can see in PDAs, ruptured sinus of Valsalva, and your aortic pulmonary window, your AV fistulas. And this alcapa is your anomalous origin of left coronary artery from pulmonary artery. Okay, usually your coronary arteries should be from the aorta, but if pulmonary artery is giving your coronary artery, that gives your continuous murmur. And Lutenbacher syndrome is your VSD with mitral defect, mitral stenosis, and any other pulmonary artery banding stenosis and coarctation of aorta. All these things can produce your continuous murmur in case of a pink child. That is, there is no mixing of blood from deoxygenated and deoxygenated. Okay, this is of memory based and entrance thing. Okay, remember this aortic pulmonary window that gives you continuous murmur, Valsalva, sinus of Valsalva rupture, PDA of course, and the AV fistulas. Alcapa gives your continuous murmur. Lutenbacher syndrome can give your continuous murmur, and your pulmonary banding is post-operation. In case of TOF, you do your Bolac, Tossing's Bolac surgery, that gives your continuous murmur, and coarctation of aorta gives you continuous murmur. But in case of coarctation of aorta, a continuous murmur will be present on the back, not on the heart. Okay, another word about venous hum, because as we discussed, this is mostly practical. If some examiner is fond of or asking you question regarding what are the other sounds of continuous murmuring, is your venous hum. Venous hum is a soft blowing murmur with 1 to 3 grade medium pitched, and it is usually in the right or left of sternal borders. And in PDA, you will get the murmur in the left pulmonary area. Okay, just remember this of anatomical significance. And in venous hum, there will be no loud S2, but in case of PDA, there can be loud S2. Okay, and in venous hum, will increase on sitting position and neck flexed, and decreases with lying down and straight neck. Okay, venous hum decreases, but PDA doesn't happen like that. Venous, it will be all through the same. Okay, these are the difference between your PDA murmur and a venous hum. Okay, because the location is the same, that is your sternal border, right and left sternal border. So you may have to differentiate between whether that is a venous hum or a PDA. And the differential diagnosis of a venous hum, your PDA comes, your AV malformations comes, your fistulas comes, and collaterals in case of coactation comes. Okay, all this producing your continuous murmurs. And yeah, coming to the X-ray, there will be a mild enlargement of the heart, because there is in ASD there is not much of blood flow and volume overload, but in case of PDA there is a volume overload, and your heart tends to become enlarged and large. So there is a mildly bigger heart, but not much of pulmonary blood flow, because the connection is happening after the pulmonary artery erases from the right ventricle. So not much of thing is happening. Okay, yeah, coming to the ECG, ECG will be normal accessed, because there is no acute overload. The whole heart takes the burden, so there will be normal load. And left ventricular hypertrophy can be present, and in the later stages, because of more work, the left ventricle left side axis deviation can be present, otherwise there will be normal axis. And there will be deep Q waves and tall T waves, because the repolarization of the ventricles will be more, because over time it is putting on more blood, subsequently. So there will be hypertrophy, so there will be tall T waves. Okay, sorry. But one thing about PDA is it will never give any ST or T wave changes in case of ECG in a case of PDA. Okay, yeah. So once you diagnosed, you found that there is a dyspneic child with infections, with continuous murmur, with bounding pulse, with hyperdynamic apex. You found a child, and you have done an X-ray with a mild large heart, and echo you have done showing pulmonary this PDA. So now, what are you going to do with it? Okay, large PDAs, then is based on the size again. Large PDAs associated with significant left volume overload will result in failure and pulmonary arterial hypertension. Okay, so your PDA murmur is unlikely to be loud or continuous. Okay, as we discussed, if it is large PDA, you won't get a continuous murmur, you will get only a systolic, just like a pan-systolic murmur you will get. The next component of the murmur won't be present because the pulmonary pressures have already set in and it is not producing the murmur. Okay, in case of moderate PDA, there is some degree of overload and there is not much of pulmonary hypertension, so there will be murmur will be continuous. Okay, in case of small PDA, small overload and no pulmonary hypertension and pulmonary, the murmur will be continuous or can be only systole. Okay, like in case of large PDA. And there is something called silent PDA. There is no murmur, there is no pulmonary hypertension and diagnosed only on Doppler. Other than that, a normal echo also, normal 2D echo will not find. Okay, that is your silent PDA. These are the types: silent PDA, small PDA, moderate PDA, and large PDA. Okay, spontaneous closure regarding PDA: small PDAs in full term may close up to 3 months of age. Large PDAs are unlikely to close. Okay, if there is a small defect and not much of pulmonary pressure changes, not much of volume overload on the heart, then you can wait and gives the baby some time to up to 3 months of age, and we can wait for it and hope for its closure. If that is not happening, you may have to intervene because PDA is notorious to cause CCF, and the heart can fail because of the blood that is being flown from the patent ductal arteriosus. Okay, and this time that is left side failure. In ASD, it is mostly the right side overload. Okay, coming to the timing of closure. Now, once you decided to close the PDA, when do you close? Okay, in case of large or moderate PDA with congestive heart failure, with pulmonary hypertension sets in, then you may have to close it as early as possible because over time you're not going to do any better to the child. Your pulmonary pressures are going to raise more, which will hinder intervention and closure. So you may have to close it as early as possible. That is, till 3 months you will wait. After 3 months you start doing the surgery or the procedure, device closure. Okay, and regarding moderate PDA with no heart failure, you can wait for up to 1 year. If there is no closure, only then you may have to close. Okay, and in case of small PDA, you can wait for 1 year or 1.5 years, but the chances of closure is less. But if the child is not showing any symptoms and no murmurs or sets in or no pulmonary pressure changes, you can wait. Okay, and silent PDA closure is not at all recommended. They don't use the procedure because there is 1% of mortality in case of a procedural injuries to the patient. Okay, and then how do you want to close it? Okay, it is individualized whether if you are comfortable with your device, and if the anatomy is permitting, you may have to close it with the device with the pigtail coils occlusion or surgical ligation in case of more than 6 months of age. This age limit, it can be done at any age actually, to be frank, but the thing is it is the ease of the anesthetist. Okay, a 3 kg physiology or a 4 kg physiology to anesthetize as a 4 kg baby and maintaining everything is very difficult. So you will allow the baby to grow for some kgs like 6 kgs or 8 kgs or be it 10 kgs. Only then the anesthetic complications will come down with a bigger muscle and bigger body physiology. Okay, device closure, surgical less than 6 months of age, and device closure can be given more than 6 months of age, or you can do it even less than 6 months of age. And regarding medical management, indomethacin and ibuprofen are not used in case of term babies. Only in preterms they're of significance. But even then, having said that, it is nothing like that. We'll give a shot and we'll see, because you can prevent the procedural risks to the child. So you just give a dose of indomethacin or ibuprofen. And nowadays there are a lot of studies on oral paracetamol. The simple paracetamol drops can also be given in case of preterm for its closure. And yes, they're finding some positive thing because paracetamol being a much safer drug than indomethacins and your ibuprofens. Okay, now coming to the preterm, but recommendation says that in term babies also there is no use of medication. Only in preterm you give a medication trial. Okay, yeah, intervene if the baby is in heart failure and at the logic stage small PDA, you can wait. Indomethacin and ibuprofen medical management can be given, and surgical ligation if drug failure or contraindicated, and prophylactic indomethacin and ibuprofen therapy is not usually recommended. Okay, hoping that the child's PDA will be closed. You cannot do prophylactic indomethacin. Only if you see the PDA and only then you give. Okay, otherwise in all preterms don't do prophylactic indomethacin or prophylactic ibuprofen. Okay, there are a lot of studies nowadays with the prophylactic paracetamol, because paracetamol has a much safer spectrum or therapeutic inference in case of a management of closure of PDS. Okay, and that concludes. And just as a ending note, PDS are bad and ASDs are good. PDS can lead to heart failures and continuous murmurs and a lot of growth defects and weight gain problems. And ASDs are very subtle, they're very calm, silent, and they can go through over years. Okay, just remember these two things. I hope I made some impression on you regarding the practicality of these cyanotic heart diseases. And somebody asks you a question in your exams, hope you can answer something. Okay, if we are open for any doubts, if anybody wants to ask any doubts, please do let me know. Hello guys. Hello. Hello.
No doubt, sir.
No doubts. Okay, as usual. Okay, I don't know when we'll be meeting again. Hopefully you'll get a word to come on. I think your exams will be in March, April, they're saying. I'm not sure. They're saying that there is a chance of postponing, but don't believe them and don't believe me also. So start preparing, and all the best with your preparation. Okay. Yeah, thank you all for your patient hearing. Okay, we'll meet again.